everybody. Thank you for joining us this morning at our Breakfast with the Boss. My name is Melissa Farhoff. I am the president of the Neshoba Valley Chamber. We were just talking about the coronavirus, and thank you to Fidelity Bank for the little hand sanitizers on our tables. We are promoting a handshake-free meeting. So we have a great panel of speakers this morning. I did not grab bios from them because apparently I was slacking. And so when we get to that part, we'll have them introduce themselves. But I'm going to turn it over to Ed Manzi, who is the chairman and CEO.
Yes.
Did I get that right? That was off the top of my head. Oh, wow. All right, I can't remember bios, but and so Ed, tell us what's happening at Fidelity.
Thank you, Melissa. Good morning, everyone. As you know, we've been supporting this breakfast for a long time now. It's a real privilege to do so, and it's a real privilege today to be disappointing you with these fine folks today we're going to hear from for the work that they do every day to protect us and keep us safe in the communities that we all care so deeply about. So I see a lot of familiar faces and some new faces, so I always like to start with just a little bit of who is Fidelity Bank. So we're a local community bank with $1.1 billion in assets. We've been serving the businesses, nonprofits, families, and individuals in the Neshoba Valley and the greater Central Mass market for 132 years. So that's a long time, and a lot of people that we've helped over the years. And it's important work that we take very seriously. We have 14 branches, and we have a very robust digital and mobile platform for you to do all your banking as convenient, in any way that's convenient for you. But the most important part of Fidelity Bank that I'd like to emphasize today is that our core values are encapsulated in our exclusive life design approach. This is our unique way of helping clients make better financial decisions with clarity and confidence. This unique approach is executed through a four-step process, very simple but very powerful, that adds that clarity and confidence, but it all begins with caring. Caring people, approaches, and solutions. A number of our caring folks here today, my colleagues from the bank, if you can raise your hand for the Fidelity Bank. Their focus is to use this life design approach to help you make good decisions about your money. And there's never been a more important time for this. I mean, think about it. Until very recently, like 2 weeks ago, I think, 2 weeks ago Tuesday to be exact, we were all agreed that things were going tremendously well. We had low unemployment, high consumer confidence, high business confidence, real estate sales are booming, stock market at record high. Today, not so sure. There's a lot of turmoil, a lot of uncertainty. The past few weeks, we've seen some cracks. We talked about it at the breakfast table. We're not so sure how quickly the world will recover from this virus that's in the news, what's going to happen to the stock market, interest rates, those kind of things. The world that we live in really is a bit of a roller coaster ride where a new headline, bad headline about the coronavirus can really turn things upside down. But as I talked to the folks here this morning, while the headlines today are about coronavirus and election results, the underlying concern of people has been going on for a lot longer than that. It's the pace, the incredible pace of change in the modern economy. It's the world that we live in, and it's not going to get any slower. Keeping up with technology, keeping ahead of new competitors, keeping up with ever-changing client demands. These challenges are part of every conversation I have. They bring stress, they bring uncertainty, and to businesses and employees alike, they also bring opportunity. You know, in the old days when the pace of change was slower and life was simpler, working with any bank would probably do. But in the world where you need to move quickly and anything can happen, you need a bank that goes beyond just the basic product, price, and convenience sales pitch that's so common in the world today. Because at the end of the day, the products and services that we offer are all the same. They're really the same. What really makes the difference is you want to work with a bank that shares your values. You want to work with a bank that takes the time to help you make financial decisions that maximize your upside and minimize your risks. A bank that will stand by you in good times and bad. In a nutshell, you want to work with a bank that actually cares. If you only remember three things about Fidelity Bank at the end of this talk, that those words would be caring, clarity, and confidence. Caring people, approaches, and solutions designed for you. The clarity that comes with the clarity of what financial options are right for you and why. and that ever-important confidence that comes when you know you made a well-informed financial decision that's in your interest, not just the bank's. Our clients tell us those three things are incredibly valuable to them. They've been saying that to us for a long time, but today in a world where it seems to me, the more volatile the world is, the faster the pace of change, the more valuable these three things are to them. So if that sounds like something, if that resonates with you, that's the kind of bank relationship you'd like to have after the program, please reach out to any one of our professionals here. They'd love to talk to you. So that's all I have to say for this morning, and I'll just turn it back over to Melissa. Thank you very much for being here today.
And we are also very appreciative of your many years of sponsorship for not only the chamber in general, but for this program. It has been, I think, one of our longest running programs that I've had the pleasure of working with. So thank you. I do want to ask everybody to please make sure to turn your phones off or on silent. We are recording this. Very special thanks to the folks from Air Public Access. And so without further ado, I'm going to invite our panel of speakers up, and they can introduce themselves. So we have we have Air Chief Murray is here joining us this morning. We also, part of our panel of speakers is Air Police Department Deputy Brian Gill. We have Air Fire Department Lieutenant John Bresnahan, and Sarah Gagney of COIN. And COIN is Community Outreach Initiative Network. So without further ado, I'm going to invite you guys to come on up and begin your program. However you would like.
Okay, can anybody hear me right now, or should you want to use the microphone? Microphone?
Yeah.
Not microphone. All right, we'll try it without the microphone. If it becomes a problem, we'll move over to the microphone. So I want to turn this. Okay, so is this working? Awesome. All right, so before we start today's program, we're going to be talking about an important topic, but yet it's a sensitive topic, and it's going to be more sensitive to others. So we're cognizant that some of the things we're going to talk about, statistically, people in this room have a very personal story that may go along with it. They maybe have been personally affected by the opioid epidemic. And if you think this is going to bother you, or you get to a topic that might bother you, we're not going to be offended. You need to just step aside and just take a moment. We've done this before, and we know the reality of the effect that this has on individuals and families. So don't think we're going to be offended if you need to step up and just take a breath. You may have some questions that develop during this while we're talking. If you can hold off to the end, it'd be really appreciative. We're kind of tight on time right now, and we do have a lot of stuff to talk about. So if you could hold off on the questions, appreciate it to the end. So I am Deputy Chief Brian Gill. I'm with the Air Police Department. I've been with the Air Police Department for about 25 years. Actually, just over 25 years. I've come up through the ranks. I was a reserve officer, dispatcher, patrol officer, detective, lieutenant, and deputy chief now. I've had a lot of experience with the opioid epidemic. When I was a detective, I kind of saw it growing, and I saw the problems that started off smaller and then culminated to where we are today. My part of the presentation, what it's going to be about, is statistics, and I'm going to show you, and it's not going to be boring statistics by any stretch, but they are going to be statistics. And what statistics help us do is try to understand where we came from here, where this kind of peaked, and where we are now, and hopefully maybe shed a little bit of light on where we're going. So we're going to start with 2019. The data just came out in February from the Department of Public Health, and last year we had confirmed opioid related deaths, 1,543 people in the Commonwealth of Massachusetts. You'll see that there's these terms that we're going to use up here: opioid-related overdose deaths, overdose deaths. You're going to see all intents. So what that means is we're not necessarily talking about injection overdoses. We're not necessarily talking about accidental overdoses. We're just talking about all overdoses. So this could be from the person who took too much of their own medicine by accident. Could be somebody who misused their medicine. Could be somebody who was trying to attempt suicide. So that's what that all intents mean. You're going to see that throughout the presentation. So this encompasses everybody. The first couple slides that we're going to talk about is kind of give us some insight into what 2019 looked like and who was the most affected. So you'll see that out of the 1,500 people, 1,100 of them were men. Or, I'm not going to say that, were male, because we'll see some ages later. And about 400 were female. So we see that overwhelmingly the male population is the population that has been affected mostly by this. Now we're going to talk about some ages. And this first column here, what you'll see is this is all the deaths in Massachusetts. So this is everybody that was reported to have died in Massachusetts. The bottom one is the opioid-related overdose deaths, all intents. So you'll see we have this huge spread of ages. And then the big age group that is affected is right here, 25 to 44, and specifically this 25 to 34 age group. So we're kind of getting a little bit better picture who the affected population is by opioid overdose deaths. A little bit more of a demographic. As you'll see, we have that same figure on the top of all deaths in Massachusetts. And then we have this big number jump out at us right here. So this is another demographic that seems to be affected more greater than other parts of the population. So 1,200 people out of that population. So we have this. So we have this age bracket. We have the men. We have this age bracket, 25 to 34, and white non-Hispanic people. So paints a kind of a clearer picture, not a clear picture, a clearer picture of maybe who the most affected part of the population is. What we have here is just kind of a timeline as to how the opioid deaths progressed throughout the years. And this goes back to the year 2000 here. So you see it started off relatively small, and it really wasn't on a lot of radars at this point. Opioid deaths happened. There were, there was prescription errors, intake errors, whatever. But they all kind of hovered right here. But then, we get to here, and then there's something that happens. Something happens, and we really start to spike. And then once we get to 2016, we're in this epidemic. And that's where we are really experiencing this problem. So you can see in 2000, for that year, we're looking at 375 people. And then by 2016, we're almost at 2,100 people that year alone just for this. So it's kind of huge. And as you can see, we've been kind of hovering right around that same number, maybe dropping down a little bit. It's a good sign. It's a little bit of an indicator. What you'll see on the top here are this little red parts, and it kind of gets bigger in 2019. In order for them to give it an absolute, they're going to say confirmed. There's some testing that has to go on. They have to do some investigations at the state level before they'll actually deem it. But what this red is, what they're calling the suspected overdose. Sometimes they just can't clear them, and it'll remain red. As you can see, they have some going back to 2017 that they're still suspecting that it was an overdose, but they're not going to call it a confirmed. So those are the numbers we're using. So you can see that although we used that number back here, 1543, the state is saying that there's almost another 500 that they're still working through, or trying to figure out if they're going to confirm or not. So in reality, our number for last year was 2,023. Let's see, this one is another way to look at it, and you can kind of see we have this same kind of trend up here. This is putting it in a percentage kind of view, and you see this trend, 2016, we kind of get right up there, and then this is the percent change from the previous years. So we got this hovering point right here from 2016, that we're up at that 2,000 level. So this is another way to look at it. This is overdose deaths, all intents by months. So this is breaking down 2018 to 2019. So you can kind of see we go up, we go down by month, and you can kind of see your winter months go up, and they kind of up and down. December, we're looking at just over 170. Just in the month of December. It's all red there because December hasn't, they probably haven't, unless there was some absolute evidence. They're still investigating, but they're all at the suspected level. So, 2018 really isn't much change in 2019, maybe a little bit lower, it looks like, up and down. But what you can clearly see here from September to October, we had a jump in the state. So this is kind of a breakdown of the overdose deaths by county. And you can see, I know I think we have some Worcester County here, Fitchburg, Leominster. So you can see from 2010 to 2018 how the trend kind of goes. Middlesex County is this line right here. And you can see Middlesex County, and I don't want you to be fooled by the numbers in Middlesex County. They're higher than all the other numbers. But remember, Middlesex County is the most populous county in the state. So they are going to be up, and percentage-wise, they're in par. So you can see 2010, we're kind of growing, and then we get to that 2015, 16, we're jumping up. And we're at those numbers here. So you can see that in Middlesex County, everything's kind of matching and it's going up. Worcester County follows the same trend. 2015, you have that big jump. 2016, and it just kind of grows. And 2008, Worcester County appears to have been kind of growing a little bit rather than kind of leveling off. Broke it down by cities and towns. And by the way, this is all public information. This is all out on the public forum in the Department of Public Health. They try to put it out quarterly. So if you want to look more in depth into your own hometowns, whatever, you can do that. But as you can see here, Ashby, fortunately, they have had 0 deaths. I'm not sure about overdoses. Air, we followed the trend. 2016, we had this big spike, and I remember that year. It was a rough year for us. We jumped up to 7A. 2017, 2018. Foxborough, not unaffected. Dunstable, not unaffected. Fitchburg's up here. In Fitchburg, don't be alarmed by the numbers. Doesn't mean that they're like way up there. Remember, Fitchburg's got a higher population than the rest of these cities and towns here. So you'll see that they follow the same trend. 2016 and 17, they had that same jump that everybody else had. Groton, not unaffected. Littleton, not unaffected. Pepperell, not unaffected. All these smaller towns, you'd think that, hey, it's not happening out there. Well, it's not happening out there if you're not seeing it. But it's out there. Shirley, same thing. Townsend, Westford. Everybody except Ashby, and great for them. but all the towns have been, have had some sort of effect. And I'm not going to believe that, that there isn't opioid use going on in Ashby. Just fortunately, they haven't had to have a death. So, what we're going to talk about now is the prescription monitoring program that was put in place by the state in 2016. And what the prescription monitoring program is it was kind of a growing program, and what it did was it told the medical community to start looking at your prescribing habits. And it started slow, it started in phases, and it's gotten to a point where we're going to see that it has made an impact. So this is breaking down some from that prescription monitoring program where this data is being drawn out, that what you're seeing is your census population in this first column here. I'm going to look at Middlesex. And then this column here is the total Schedule II opioid prescriptions that were issued in the Q4 of 2019, so October, November, December. So in that time frame last year, there were a total of 84,916 Schedule II opioid prescriptions written out. Of that, 4,252,182 dosage units of an opioid prescription that were issued to patients. Individuals, 42,000. So of that constituted 42,000 people in Middlesex County. And what that equaled as a percentage, 2.6% of the population. So remember, those numbers may be a little higher than the other ones, but that's because the population is higher. And so it's 2.6% of the population compared to Hampshire County, which is, they're at 3.5%. So the percentages are the ones where it's really important. But I think this column here is important to visualize how many prescription units, how many dosage units are out there, being put out there. And then out of all of that in Middlesex County, because of this prescription monitoring program, they've identified 32 people, only 32 people now, that are areas of concern. So through this program, they've been able to say, all right, these are 32 people that they're going to watch and make sure that the prescription process isn't abused. And how it gets abused is you go to one doctor, I got a toothache. Go to another doctor, I got a toothache. And you're hoping that they don't connect the dots. So out of all that, that's that 32. So they're watching 32 people, or they've shut down 32 people. And that equals 0.8% of the population. So it's a super small percentage of the population now. That number, sometime back when this started, was higher. So, it's a success. What this is, it shows how the number of prescriptions that are out there compared to the mass patch searches that have been done. So, in 2015, you'll see up here, this is the opioid prescriptions that are out there. 2,500,000 prescriptions are out there in the state. And then it starts to go down as the mass PAC program starts to come online. And these searches are being done, and individuals are being challenged, like, why did you go to this doctor, and then this doctor didn't get a prescription. So you'll see this line here is the increase in the use of the mass PAC program, where everybody involved in the whole process is part of the checks and balances. So as these checks are increasing, the prescriptions that are being issued out are decreasing. So we're reducing the number of people who actually are not in need of these valuable tools in their, of pain treatment, and they're getting it down to probably where it needs to be. So a couple of important dates here: December 7th, 2015. That's when the pharmacies started using the mass PAC program, and that they were kind of talking to themselves within this program, saying, hey, I just gave 90 units of an opioid out. How come he just went down, 2 towns over and got 90 more units? So they started talking that way. 2015 is when, this March 15, 2016, that's when the state passed the STEP bill, a very important part and tool in the process. The STEP bill was the Substance Abuse Treatment, Education, and Prevention is what it stood for. And one of the things that it did was it mandated by October 15th that all people part of the prescription process use the MassPad program. And they got it live, they got it on live August, and by right here, October 15th in 2016, you can see there's this huge jump in the amount of inquiries that have been made into this system. And I mean, the data is kind of clear. The more that we've been using this system, the less opioid prescriptions that are getting or being pushed out. So this is a kind of a trend that we're noticing. As you can see here, we got this kind of this line that's kind of bouncing around. And what this is these are deaths involving opioids and stimulants. So the purple line here is the deaths involving all stimulants. The red line is a combination of opioids and stimulants. Now, just something I know what a stimulant is, and I know what an opioid is. So a stimulant could be is what we're finding is a lot of cocaine. So they're mixing cocaine with what we're finding is an opioid, and the opioid of choice is turning out more and more to be fentanyl. And we've got a slide to talk about that. And very little are we seeing, this stimulant of just cocaine overdoses is kind of remaining constant. Where the cocaine overdoses are, they're happening more with the combination of the heroin or the fentanyl. And what we have here, it's a whole bunch, there's a lot of spaghetti going on here. But this line right here, that is fentanyl. So what we're seeing is, and if you follow the line, it's right here, fentanyl being used as the primary agent is being more and more used in the drug process, in the illicit drug process. This line right here, this red line that's dipping down, all the bankers in here can kind of recognize this, the trend here, that the heroin content of the opioid deaths is going way down. It's being replaced with fentanyl and cocaine. So cocaine is going up and being mixed with fentanyl. So it's not an old, it's not a new trend. It's just something that picked up. I don't know if everybody, in their days have heard of speedballing. That's what that is. It's been mixing an opioid with the cocaine, and we're just losing the heroin, and we're going to the fentanyl. The problem with the fentanyl is, and Lieutenant Bresnahan's going to talk about that more, is it's tough to combat fentanyl. It's so strong that our tools, just a single dose of what we can do as a life-saving measure, isn't working just in one dose anymore. So we've got to fight even harder to help somebody. So fentanyl is a major problem. And what we're finding is not the medical grade fentanyl. The medical grade fentanyl, is pretty much being used for what it's being used for, but it's a chemical and it's being synthesized easily overseas and being brought into the country. And that's a huge problem, because that's what's killing people now, is that. So if you see an overdose, don't run, call 911. This is an important program that was also put into play in that 2016 STEP bill. And what that is it protected people who, what we were finding were, we were going to these overdose situations, and there was a party, maybe 2 or 3 or 4 people, and they were getting into their opioid party, and then their buddy would, start overdosing. Well, they were more concerned with, if they called 911, they knew the police were gonna show up, and what they were gonna do was not, they were gonna clean the house up, they were gonna get rid of their drugs, they were gonna do the, 45 minutes later, they'd call 911 and say, my buddy's overdosed. When we get there, their buddy wasn't overdosed, their buddy was dead, because they waited. So this was put into place, saying, hey, call 911. If and basically the message is, if you guys party and your buddy overdoses, call 911. The drugs that were there, because you guys are, you're users, you're not gonna get in trouble for it. We're not gonna charge you for it. Call 911. We'll get there, we're gonna take them away from you, don't get me wrong, but we're not gonna charge you criminally for it. So the Good Samaritan Law is what that became known as. So it forced people, it's not forced, it encouraged, strongly encouraged them, said you're not gonna get in trouble. It prevented the people going to the hospital ER rooms and throwing their people out of the car and driving away, where you had no idea, because sometimes the information is super important to the EMS arriving, that, hey, what did the person take? How much? So we can start making the necessary emergency things right there on the street to try and save them. Real quick, we heard a lot of stuff lately last year on the Purdue Pharma civil suit. Massachusetts broke away from the national class action suit, and everybody's like, hey, why don't we jump in on the $3 billion? Well, one of the reasons why Massachusetts was one of the hardest hit of the opioid epidemic, believe it or not. So Massachusetts said, wait a minute, the Sackler family, they all got out of their business. They got out of, they resigned or whatever they did, or just went in from the business, but they left. And they are leaving the Purdue Corporation to pay that fine. Whereas the Sacklers themselves, that family, they all made billions of dollars before they left. And they said, we're jetting. And we're gonna break away from the company, and maybe they'll start up again somewhere along the line. Massachusetts said, no, we're gonna go after you, the family, personally. And we're gonna go after, and that's why you see all these people named in here, not just Purdue Pharma. Because they're saying, you individually, all of these people here, all of these Sacklers individually made billions of dollars off of the OxyContin drug that their company made, that they pushed. And one of the key things that they used to the doctors, they told the doctors that, and these are in email correspondences, that, and this started in 1996, that OxyContin is it's going to be better than Percocet because it's not addictive. So they said, push OxyContin. All right, so real quick, okay, 2 times a year across the country, there's what's called the National Prescription Drug Take-Back Day. Happens twice a year. We've been participating in it for years, even before we had fancy drop-off boxes. And this year is April 25th, 2020, 10 a.m. to 2 p.m. It's a great program. What it does is it stops people from flushing their drugs down their toilet, which pollutes our water supply, which we're finding out now that, that if you were to test your water supply in most metropolitan areas, you'll find that there are trace amounts of drugs. What's that doing to us? They don't know. So stop flushing them. What we do is we take them back, and we properly destroy them with the DEA. Hopefully they don't have a big toilet somewhere in there flushing. No, they're burning it. So we have two times a year, and we generally destroy, believe it or not, on these 2 times, we're upwards of over 100 pounds that we're destroying, which is amazing. So, almost every police department in this room, if not the state, has some form of this little box right here. And what it is a prescription drop-off box. We're open 24 hours a day, 7 days a week. We will take your prescription drugs, no questions asked. Well, actually, we'll take all your drugs if you want to drop off whatever you got. No questions asked, no appointment, just show up, and you put them in the disposal. It's like a post office box, post office mailbox. Just goes in, boom, goes into a box. Once a month, we have to empty it out about, I don't know, 20 pounds. You know, that's, you know, it's just another way that we're preventing, you know, unused drugs from not only going to the water supply, but what we're, you know, you find if you got, you know, if you had a, you know, some sort of procedure and you have this, you know, Percocets or Oxys or oxycodones, you know, in your medicine cabinets, that was an opportunity for diversion. So, you know, it was important that we're getting the message out, don't leave them around, get rid of them so they can't be diverted onto the street. Okay, so with that, I'm going to hand it over to Jennifer.
Thank you. So my name is Lieutenant Bresnahan. I'm with the Air Fire Department. I've been a paramedic for I've been a paramedic now for almost 20 years. I've worked for the town of Air for the last 16, and I've worked in urban, rural, and multiple different public and private agencies as an EMS provider. So what I'm going to talk to you about today is just what is an opioid and how do we combat it when you're out the street. So what does an opioid do? It's a pain reliever. It affects your entire body. This is why it's so dangerous for people when they overdose on it. It affects the brain. It affects the lungs. It affects the heart, the spinal cord, the peripheral vascular system. What does it do? It actually goes in and it blocks those receptors. So the opioids bind onto those receptors, and in a normal dose, it's going to relieve pain, because how do you feel pain? It's the nerve receptors. So it gets on there, it binds, it kind of blocks that pain reception. The problem comes with when we start to take too much, it binds onto those receptors and it stays there. And as we increase the dose, it starts to bind on and it slows the breathing, it slows your mental status, it kind of just lowers everything down to the point where, okay, that person has now stopped breathing. And that's the primary problem with an opioid overdose, is it doesn't actually stop the person's heart, it actually stops their breathing. It suppresses their their brain and their brainstem to the point where they are no longer breathing on their own. And when you stop breathing, what happens is slowly your heart starts to slow down and it stops. So what we use is naloxone. So going around right now is just some saline. I'll explain that in 1 second. So Narcan or naloxone, I'm sure everybody has seen this on the news, heard of this on the news. I'm going to pass one of these around. You can take a look at it. This is actual Narcan. This one's expired. We take it out of our stock and rotate it around. Actually is a drug that will go on and not only bind to that receptor, but it will actually force the opioid off of the receptor. That's why this is such a powerful drug. And it goes in there, it jumps on, and it forces that opioid out of the system. Or off of that receptor, excuse me. And then, yes, it's still floating around in the system. That's where the problem comes in. Like the deputy talked about, is right now fentanyl is out there. Fentanyl has a lot longer half-life in your body than, say, heroin or morphine or opium, because this isn't a new subject. You know, there's been opium and laudanum out there since the 1800s. It's all the same thing. It's just become more potent. And that synthesized fentanyl is about 100 times more potent than morphine. And I'm sure everybody heard a few years ago when they were talking about carfentanil and how deadly it was. That's 100 times more potent than fentanyl. So this stuff is very, very potent. And what happens is, yes, the Narcan goes in, it knocks it off the receptor. Hey, they wake up, they start breathing, they're doing a lot better, their mental status improves. And this is almost instantaneous. It goes in, and within 1 to 2 minutes, that person is wide awake and very unhappy because I just took away their high. But they're alive. The problem comes is that fentanyl can last for hours in the system, depending on how much they took. Narcan lasts about 15 to 30 minutes. So you actually get these rebound overdoses. So if they're not monitored and they're not watched, there's a potential for them to, yes, hey, we got you breathing again, you're doing well, They walk out of our ambulance, they walk out of the ER, they walk out of the house, because you can pick this up at any pharmacy now without a prescription. And all of a sudden they take it, 30, 45, an hour later, hey, they're unconscious in a snowbank somewhere. It's not going to be a good outcome. So the Narcan that I'm passing around is the typical stuff that we carry on the ambulance, right there. There are also other forms of this. So this is some of the stuff that you can buy over the counter. It goes up their nose, they push the plunger on the bottom, and it gives them a dose of 4 milligrams. The stuff in the pink box that's going around right now is 2 milligrams. We dose it a lot lower than what they would give, somebody, a lay rescuer, just because I can taper it. And I want that person to wake up slowly, because if they get slammed, they're gonna wake up and they're gonna be very angry. So if I can slowly bring them back up so that they're breathing and their mental status starts to improve, it's much better on not only the patient, but also on the providers, because these folks do get violent sometimes. They don't like us waking them up. The last few we've woken up, it's like, oh, you Narcan'd me? Oh, we've been down this road before. So, this is an injection style, similar to an EpiPen. If anybody has an EpiPen for an allergic reaction, the third style up there is very similar to that. You stab it in, and it's all done. Automatically injects. And the last one is your intramuscular or your IV. So that would be used at the hospital. So for these people that have taken a large bolus, a large dose of this medication, they can actually start them on a drip to keep them evenly dosed over a period of time until all of the opioids are out of their system. So like I said, Narcan starts working instantly. It just needs to be absorbed, and it instantly works on the nervous system and starts booting those opioids right off of those receptors. Kicks them right off, stays in your system for about, anywhere between 15 and 45 minutes, and then it starts to wear off. Your body actually metabolizes it out. If the opioids are still in there, unfortunately, they reattach to those receptors. The biggest problem, like we talked about, is the respiratory depression. They're going to start to breathe a lot slower. They're going to seem like they're sleeping. That's exactly what most of the problem is some of these overdoses, they're not recognized for a long period of time because they think they're just sleeping. They're sleeping, but they're not breathing. Or they're breathing 3, 4, 5, 6 times a minute. That's not adequate. The pinpoint pupils, another telltale sign. If their pupils are very, very small, and I'm talking the tip of a pen small, probably a good chance that there's some form of an overdose, an opioid on board. And obviously the first two lead to the unresponsiveness, because your brain is very, very dependent on oxygenation. And if you don't have that, and these opioids in combination, will become very depressed and they'll become unconscious. The unfortunate thing is Narcan is very ineffective if the person has already gone into cardiac arrest. We still give it, we still try it, but if that person's heart has stopped, we have to restart the heart before the Narcan will work. So the earlier we can get this into their system, the better. So the saline bullets, the larger tubes that I pass around, they had a small plunger on the top of them. That's actually what we're using pre-hospitally now. It's a nasal atomizer. So if you've got one of those, if you're passing that around, you can actually squirt it, and it turns the medication into a vapor. And you can actually put that right in a person's nose. That's what the first two were that we had up on the screen. And it's absorbed as well, doing it that way, as waiting for an IV. So I think there's one on the table over here, and I don't know where the second one went. But if you just take and you atomize this, and these are saline, so this is completely safe. I don't use the drug because it gets sticky when it dries out, and people get angry. So you just take that and give it a squirt, and it turns it into just a fine vapor. And they're actually able to absorb that right through all those mucosal membranes in their nose, and it goes immediately into their circulatory system. It is just as effective as doing an IV. So you don't need to wait and do this IV. If you're at home or you see somebody, you know somebody who has an opioid problem, a lot of people have the Narcan at home. Police departments are carrying it. Fire departments are carrying it. EMS is carrying it. So it's out there. If anybody wants to try, please feel free. You can see how this works. I wouldn't suggest squirting it up each other's noses. It might be a little uncomfortable, but it is very, very effective. With that,
So while you all are looking at that, hello, my name is Sarah Gagne. I am a licensed mental health counselor. I've been working in the field for about 10 years. I've been working specifically with COIN, the Community Outreach Initiative Network, for about 2 years. So what is COIN? So as you were hearing, 2016 was a big year, so there were a lot of overdoses. So typically in this area, fire and police are both responding together to overdoses. So they're amazing at what they do. They, revive people, they're responding to emergencies, but they're not treatment providers. So as much as they want to help, it's just not within their wheelhouse to know what to do next. So what comes next? So at that point, it began in Pepperell, which is the lead agency, but there was an idea to get a grant for a jail diversion program. And because the towns are smaller and regionalized, if you're from the area, you know that things that are happening in Pepperell are also happening in Townsend and Ashby. Things that are happening in Ayer are happening in Shirley. So it was decided that we were going to collaborate as a region. So these 10 towns, which I've memorized in alphabetical order, are all using the Ayer District Court. So that was how it was decided that we're going to work together. So the idea is that when somebody comes into contact with police, they want to have some type of follow-up. So you're reviving the same people over and over again. You are going out to the same homes, and it seems like, they may want or need help, but there's really not much that you know what to do other than just referring them out. So the 10 towns came together and were funded by the Department of Mental Health, so as a jail diversion program. So what that means is, the hope is that if mental health and police forces combine, that we'll be able to work together to get people the resources that they need. So the staff that is funded by the grant is myself, a clinician. We have a case manager who does things like help people find housing or insurance, which are huge barriers, especially if you're homeless and you're actively using drugs. It's very difficult to get to that next step if you have nowhere to go at the end of the night. And then we have a recovery coach, which I'm going to speak of, which is an amazing tool to have. So how does the program work? So anytime a police staff comes into contact or gets called to a home for something that's mental health or substance use related, they do send a referral over to my team. So whether that be a couple got into a fight while they were drinking and there was a huge domestic, that will come to us. If somebody overdosed, that will come to us, because like I said, the police are responding to the overdoses as well. If a child has a mental health issue and runs away from home, that will come to us. So we get the referrals from the police departments, as well as our information is in all the departments. So if somebody comes and there's no direct contact with the police, they're always welcome to contact us individually. So we cover the 10 towns, but we're not exclusive to the 10 towns. So if somebody comes if we get a referral from a different town, we won't just say, oh, you're not in our 10 towns, we're not going to help you. We'll refer to the appropriate resource, and we will connect them to people in their area. As you know, some of the towns are close to New Hampshire as well, so sometimes we'll get New Hampshire residents that just happen to have come into the area towns. It's a voluntary program, so it's not, people can tell us where to go, or they can accept our help if they want. It doesn't really have an impact on if you have a case. If you don't respond to it, it's not going to make any difference to what's going on with your police involvement. So what we hope to do is, we get the referral to follow up within a business day. We'll reach out initially. We don't always get through to people right away. People don't always want to talk to us, which is fine, but sometimes we'll find that people will have our information, know who we are, and give us a call back a month later, maybe when they're feeling more ready for help or when they are needing something. So some of the services that we offer, so we first and foremost are referring to other agencies for more long-term treatments. So we can be short-term treatment providers. If somebody is coming and there's a wait list for a program, we can provide some of those short-term services, but the hope is to get people in long-term treatment and to be followed up and to have these resources so that they're not calling the police as often. They know where the local emergency service providers are, so they know maybe instead of calling the police, I'm gonna call Riverside or Community Health Link or one of these services to get the more appropriate service. So the hope is that it takes some of the burden off the police and that they're not responding to calls that aren't necessarily emergencies. So with that, we're not an emergent service. So we always encourage people to call 911 if it is an emergency, but we do follow up and we do provide that resource as needed. Like I mentioned earlier, we have the case management services. So we have an individual who will meet with you and say that you need insurance. We will sit with you and we'll fill out the application with you. We'll answer any of those questions. If you need to find a treatment program, you just don't know where to look, we will give you a list, we'll help you, we'll call with you, we'll find something for you. We have connections at different providers, we'll try and get you in more quickly. We'll do everything we can to get you connected to the resource that you need, especially post-overdose. Typically, when there's an overdose, you want to get the person as soon as possible because then they're motivated for treatment before getting back into that cycle of use. And again, so some short-term direct service, which includes our recovery coach. So in 2019, between the 10 towns, we received 535 referrals for mental health and substance use calls, and 205 of which were directly assigned to our recovery coach. So that includes opioid related referrals as well as alcohol, cocaine, methamphetamines, really anything that is a substance. We are getting those referrals. So what is recovery coaching? So recovery coaching is a little bit different is that it's not treatment in a clinical sense. So it's not the patient-client dynamic there. It's more so of a mentor. So it's somebody who has lived experience, somebody who is themselves in recovery. So I believe in order to go to the training for recovery coaching, you have to have been in recovery for at least a year or longer. Through the Bureau of Substance Abuse Services, there are programs in which you can go to and you get all the education and the supervision and the training in order to respond to these type of situations. So it's peer-to-peer. It's initiated at any stage of change. So an individual could be not ready to stop using now, but the recovery coach can work with them around harm reduction, about safe use, if that is what needs to happen until they can get to the next point of treatment seeking. It also acknowledges that in recovery there is relapse, so the person is not going to be shut off or cut off from services if relapse does occur. The recovery coach will be with them during that and to get them to the next level. So it's self-directed, strength-based, and individualized, so it acknowledges that everybody's experience is different. There's no one way to be in recovery, and that the individual is the one who's calling the shots. Whereas a treatment plan is built collaboratively rather than somebody telling you, here's what you need to do, here's what you should do. It's here what works for you, what makes most sense for you. So coming to that is identifying that there are many pathways to recovery. So not everybody does well with AA. Not everybody wants a 12-step program. Not everybody is faith-based or wants that type of treatment. Not everybody wants to go to counseling. Not everybody wants that. It's identifying what's going to work for you and trying different things out maybe together. Also identifying some people benefit from medication-assisted treatment like Suboxone or methadone. Some people really thrive from that. Some people don't. So it's working with the recovery coach to identify what makes most sense for you, how are you going to thrive in your life and your goals. And that's including making sure that the individual has all their basic needs met so that they can move on. So, like I said, if somebody is homeless, their first priority might not be, oh, I need to stop using right now. Maybe I need somewhere to stay tomorrow, or I need something to eat tomorrow. Another choice, some people choose to go to peer recovery centers, so going to meetings that are just their peers. Some people want to go to treatment programs and be in treatment programs for a long time. So the hope is that with partnering with the police stations, we will be able to provide that resource for somebody who's coming in that doesn't want any punitive damage, but is genuinely seeking help. So we are there. And this is our contact information. So we are always accepting referrals, and we work very collaboratively with the police departments so that they can really direct people in treatment, because they are very caring and understanding as well. Just showing people in the community that police aren't always looking to arrest you, they're looking to help you and to be supportive, which is a very important message, I believe. Thank you.
Thank you.
Anybody have any questions that we want to address right now? If not, we can close it, and if you want to talk to us after, we can go later on afterwards too. So.
For being here and us having this conversation. It's definitely something that we need to continue to have the conversation, as, you know, and hopefully as we continue to talk about it, that will, you know, help everybody. And I appreciate that you have the resources available. We have a small token of appreciation from the chamber. Thank you very much.
Thank you.
And I also thank you for helping coordinate. Very special thanks, again, for our team. And you can hang for a minute if anybody has a personal question that they want to come and ask. Very special thanks, of course, to Fidelity Bank for once again sponsoring our Breakfast with the Boss series. Thank you to Air Public Access for joining us this morning and recording. Thank you to JNS Photography for taking some photos. Make sure you get my good side. And of course, thank you to Hilton Garden Inn for having us this morning. And I hope that you have a wonderful day. Take your little Fidelity Bank spray and have a wonderful day. Thank you.